Thank you, everybody, for joining us for the session with the sort of quote kitschy title, "Thank you for taking over buprenorphine prescribing for your patient who has now been discharged from RAAM." And just to let everybody know that this is really oriented towards people who are new or new-ish to buprenorphine prescribing. So if you're someone who's been working in this field for a long time and you're looking for, sort of updates on fancy initiation, this is not the session for you. There will be others. But we're really hoping to use this as an opportunity to get people feeling more comfortable with prescribing buprenorphine, whether in a primary care setting or a RAAM setting. So sorry, Stuart, that I just totally took over that. I'm Jennifer Wyman, and I'm happy to co-present with Nikki Bozanoff and M. Wadden. And we'll welcome questions, comments in the chat. We'll have time at the end, but if there's something that comes up as we go through that you think would be relevant, we'll try to make sure that we address it. This program has received in-kind support from CAMH and the Division of Mental Health and Addiction of the Department of Family and Community Medicine at U of T in the form of logistical support. And we have no potentials for conflict of interest. So personally, I have no relationships with commercial interests. I've received honoraria for developing the MAC Health opioid modules. I received salary support from Medify as an education lead. Oops, sorry, I was supposed to introduce myself. I'm a physician, family physician, addiction medicine physician, living and working in Toronto. I now work at Women's College Hospital with the substance use service, and I'm the medical director there. And I work with Medify as the education lead and clinical programs lead. And Medify is the provincially funded organization that is sort of the hub or the home of Ontario's rapid access addiction medicine clinics, and works at developing guidance, education, and leadership activities to improve the care of people who use substances. So in terms of research funding, I have some funding from CIHR, innovation funds, Women's College, and I will recommend CPD from a variety of organizations as a mitigating position. Nikki.
Great. Hi, my name is Nikki Bozanoff. I'm also a family physician trained in addiction medicine. I work at the Center for Addiction and Mental Health, and I'm the division head for mental health and addiction at the Department of Family and Community Medicine, University of Toronto. My research is in the area of opiate use disorder. I get honoraria for continuing professional development activities, some of which are related to OUD, from the Ontario College of Family Physicians and CAMH Education. I also have research grant funding from the following agencies, and I will mitigate potential conflicts of interest by recommending CPD from a variety of organizations nationally. And please put your questions in the chat. We're a small group, so there should be lots of opportunities for interaction today. And I will pass it on to Em to introduce herself.
Perfect, thank you. My name is Emily Wadden. I'm sitting here in St. John's, Newfoundland, and I am many things. Here today, I am a person who uses drugs and is on Suboxone or Bup, whichever. And I'm also a social worker by trade and work in the area of harm reduction, managing Newfoundland's sole kind of harm reduction need distribution site, etc.
Thank you. And we are so happy to have you as part of this presentation, bringing a very important perspective. So we are going today to try to think about how primary care offices can be made into safer spaces, welcoming spaces for people who use drugs, and work to develop an understanding of some of the ins and outs of buprenorphine prescribing, such as dose adjustments, writing prescriptions, dose increases and decreases and tapers, the role of urine drug testing, and then hopefully a little bit on treating acute pain for patients on buprenorphine. So we thought we would start some interactivity. This poll, you're going to have an option to answer true or false in a moment as our tech support puts up the question. The naloxone component of buprenorphine naloxone contributes to the effectiveness of the treatment by blocking opioid receptors. True or false? No one can see who's answered what, even in this nice small group. So feel free. Again, it's just a chance to sort of warm up our brains and thinking about buprenorphine, naloxone. Okay. So pretty evenly, we're sort of edging up on the false over the true. Again, in our vast group of people, so pretty close to 50-50. So what does the naloxone actually do in buprenorphine naloxone tablets? It does nothing when the tablets are taken sublingually. It's not active. The naloxone is added to the tablets to deter people from injecting them, because if you, as you know, naloxone is an opioid receptor blocker or antagonist. That's why it's used for reversing opioid overdoses. And if it's injected, it will cause that very unpleasant reaction. So it was added to the tablets to help deter people from misusing them through injection, but it is not absorbed when the tablets are taken sublingually. So it doesn't enhance the activity. It doesn't create any sort of negative feelings or aversive reaction if someone uses opioids while they're taking buprenorphine Suboxone tablets. Next question. Nikki.
The next question is, patients who take opioids while they're on buprenorphine will get terrible withdrawal symptoms when they take their next buprenorphine dose. True or false? Poll, please. Here we go. All right, we have 17 people, so I'm gonna wait for everyone to reply. No.
I wasn't so patient. Is that what you're saying?
Okay, we got some false. Right. Okay, great. So it sounds like people know this answer, right? So if you have buprenorphine in your system and then you use opioids, other opioids on top of the buprenorphine, you will not go into withdrawal. And so buprenorphine in this way, if the patient's goal is to continue to use other opioids, buprenorphine in this way can act as a harm reduction measure. So you have this kind of long-acting opioid as a backbone that gives, that protects from withdrawal, so you're not having highs and lows. And then if the person's goal is to continue to use, fentanyl or other substances on top, then they can certainly do that. However, what some people sometimes worry about is this idea of precipitated withdrawal, which we'll talk about later, but that's not a concern if the person is regularly taking their buprenorphine. All right, next question.
Okay, so your patient has been on their buprenorphine, formerly known as buprenorphine naloxone tablets, which we call Suboxone in the real world, for 3 weeks. Their dose is 16 milligrams. She reports having frequent thoughts of using pills. She's even having using dreams. When she started treatment, she really didn't see herself being on it for long. So what would you advise with respect to her dose? Should she begin her taper because she's already been on it for 3 weeks? Should you leave her dose where it is and see if she's feeling any better in a couple of weeks? Or increase her dose a little bit and see her again in a week? Great. So this is something that we will talk more about in terms of dose adjustments. But the goal of, I'm hesitating to say the words treatment, because treatment, I feel, sometimes has a very specific abstinence focus. But the goal of using buprenorphine is to help people feel well, feel normal, not have withdrawal symptoms and cravings. And so if someone is identifying those thoughts and urges of using, that's creates a risk that they're going to use if their goal is to reduce or avoid their use. So we would want someone to be feeling quite solid and stable in terms of their use before even thinking about tapering off and reducing. And if they're identifying that they're already having symptoms, then we would absolutely want to have a conversation about increasing their dose. And the question of by how much really depends on how intense or severe those thoughts and urges are, whether they're having withdrawal symptoms, how early in the 24 hours, etc. So yes, the decision is absolutely a decision that is arrived at through conversation and discussion. I appreciate what you're saying, Katie. I guess I'm sort of thinking about the overall kind of trajectories, and absolutely true that a patient-centered care involves looking at the pros and cons of any of the decisions, the individual's goals, and then having those conversations around sort of, playing things forward. What are the pros and cons of any given decision overall? Next slide, please. I think this is where we get to hear from M about, things you
Fair.
want to share with new prescribers. Thanks so much.
No pressure. No pressure. Just, 5 minutes. I'll try to fit it all in, I guess.
Everything we should know.
Right? So I guess not only thank you guys for the opportunity, and thank you to everyone who, attended this session, because this is kind of the opportunity that a lot of patients or just people who use or have used drugs don't often get. And when they do, it's I don't think people always listen. So a couple considerations, and again, I'm touching on them quite briefly. I would encourage you to kind of, explore them more. But a few considerations that I think they're some of the top things I think are very important if you're going to embark on, this expansion of your practices to include prescribing bupe or Suboxone. I'm going to refer to it as bupe because it's just 2 syllables, whereas the other word is a lot longer. And I am not afraid of using slang. So the first thing is set and setting. And like a lot of times this is it's associated with like drug use outside of, obviously the formal doctor setting. But I feel like it's also still very relevant. And by set and setting, set describes, the patient's mindset, motivation, and kind of overall mental wellness at, a particular point in time. And set is usually, influenced as well by, like, for example, what patients think about Suboxone and their expectations, both short-term and long-term, when choosing, to try this course of treatment, possibly for the first time. So it's about the individual, it's how they feel, what do they think, what are their expectations, etc. The setting describes the physical and social environment, which obviously in this context would be, where is your practice located, from, the bigger building or inside like a larger clinic where you have an office. Some environments are certainly comfier than others, and even little things like, I don't know, not having a sharp spin in the bathroom, or having posters that promote abstinence-based treatments, or, signs just right on that front door saying, this clinic doesn't prescribe X, Y, and Z types of drugs. All of these little things are noticed, honestly, by patients or people who use drugs, because we're used to being excluded, of course, right? So this is important because it probably dictates how safe, honestly, patients may or may not feel. And I encourage you just to be mindful of all of these little things, right down from posters to, your conversation that you'll eventually have once in the office about starting prescribing. It's all so important, and people do take notice, I have to say. So next, the language. I could go on in detail about how important the language we use about, people who use drugs, what we think of them, et cetera, et cetera. I could go on for days, arguably. So very briefly, and again, would encourage you to kind of, continue this I don't know, exploration, is that the, I don't know, but keep it front of mind and maybe give it a little Google eventually when you have time, which I know most of you do not. So the language that we use both in, personal and professional settings when talking about or directly to people who use drugs, it's a really big tell and giveaway about how you actually feel about drugs and those who use them. People don't have to tell me how they feel about, you know, treatment or drug users or any of that. It's very obvious from the second they open their mouth, just based on the words they use. Abstinence isn't the only, oh, my bad. Oh, yeah. Abstinence isn't the only solution to drug addiction or drug use. I even, stray away from the word addiction. But this is often, it's often implied in how we speak or the perspective that we kind of, bring, or what we think is the most correct way to treat, people who use drugs. And the language that we use, or the specific words, sorry, that we use to talk really about anything, they're a choice. There are arguably synonyms for most, if not all words, I would say, in 2024. And we use, and like, though we oftentimes, we use words that that we hear the most through like media, maybe our colleagues, the people, our family, or in school. And it's so crucial to consciously pay attention to the language and the words most specifically, used particularly in conversations about people, places, or things that have a history of, hardcore judgment and assumptions. I will give you some examples, but language in general, it's either going to contribute to stigma or it's not. And it is also one of the, I would say, major contributors of stigma, and one of the easiest ways to perpetuate it, across society, all subject matters in any environment, etc. For example, and actually, let me go back before that. For example, we, like, a lot of times, again, this is automatic. We are not aware of it, and nor does it necessarily come from a place of actual like malice. Intent versus impact, obviously two very different things. So having the best intentions is great. And what is the realistic impact of using, for example, addict versus drug user? One is very stigmatizing, or the idea of, abusing substances versus just saying use drugs, because you can't abuse an inanimate object realistically. Like, you can't abuse powder or whatever, right? So very, I don't know if they're subtle things. To me, they're very big things, but please, I beg of you, please pay the most attention to your language. I think, no, we haven't touched on it yet, I don't think, but urine drug screens. A lot of times this elicits language like clean or dirty. Because if you, say, oh, the result is this person's clean, well, that then implies that those who are still using drugs are then dirty. So just saying what it is, like positive or negative test result, just someone is sober or actively using, right? Like, those two words in particular, I think they cause a lot of havoc and are very commonly one of the things, at least that I see repeatedly, that people just aren't aware of. It's all they've ever known, it's all they heard, and they've never thought of the implications of, calling something, or a positive, negative, sorry, medical jargon that confuses me, calling a negative drug test anything but clean. They don't realize that, well, what's the opposite of that, right? And lastly, you're going to hear me say drug user or drug users throughout this presentation. And I would argue that, I've earned that right as a current and active drug user, whereas for those who don't use drugs, and especially in this context, because you hold a great deal of, power over people, person first language, people who use drugs, that's the preference. So again, be mindful if you could. Again, sorry, I don't know why I said again there, but so personal, I am also I'm going to jumble personal versus professional values and bias and stigma in one kind of go here, and then I'll touch on the meaningful choice. But it's so important, I guess, let me restart that. It's so important to reflect and recognize our personal opinions, beliefs, values, etc., and not let them impact our service to others. In addiction care, I've experienced a lot of, what practitioners, actually, no, I'll save my opinion for the after, but in addiction care, what practitioners, do and don't do can be heavily influenced by like opinions or personal points of view, or, just not science. Whereas everything else, I would argue, probably within the scope of your practice or any other area, like science and facts are generally dictating the best course of action and the best outcomes. But for patients who use drugs, there's often this type of like moral superiority and this assumption that, people who use drugs aren't competent to be active in their care and treatment. And sometimes like people who use drugs are not competent, they don't know things, and therefore their course of treatment is often just kind of determined not by facts and science, but sheer opinions or points of view, or what people have grown up to believe to be the best way to treat addiction or drug use, etc. Like I said earlier, a lot of people you're not aware, right? We don't know what we don't know. And in this realm, where people are used to and viewed as not even human, and they've been so traumatized by formal systems, by healthcare, by justice, etc. I beg of you, please examine your personal values, beliefs, etc., because active reflection is so necessary here, because a lot of this is automatic, right? Like our opinion about people who use drugs arguably started forming as very little children. Even just the first time any media we were consuming, depicted drug users as zombies or very violent and dangerous, and humans that kind of wreak havoc. So this runs very, very deep, and it's been pre-programmed in us from a very young age. So we're not even aware most times of the words we're saying, or what we even unconsciously think about drug users, how that actively very much comes out in our practice today. I'm assuming I'm getting very close to time, and I'm getting a look here. I don't know if you guys can see the look, but I'm getting a look. And then briefly, I'll just touch on this, what I wrote here about meaningful choice, right? Like when I say that, and I guess, first of all, it falls under this idea of collaborative care, which arguably contributes heavily to positive patient outcomes and success. But part of collaborative care is certainly this idea of meaningful choice. And what I mean by that is, I think we're not always maybe aware of not just I guess people aren't always aware and say things just to say things. They don't say things with this, with the intention of maybe following through on that, or they just say it to say it without recognizing the real potential impacts and consequences, in that interaction. So when speaking to patients or talking to them, yes, collaboration, absolutely. I highly recommend, valuing people's opinions, thoughts, because again, people who use drugs are not incompetent. While I do not fit, maybe the stereotype, and I have an extreme amount of privilege, because I don't look like I use drugs. Social worker by trade, yet I am smoking crack every single day, right? All day, every day. And I can do both because, again, drug use doesn't take away, my smarts or my ability to, just interact and be a human in everyday life. So please don't think people don't know what they're talking about. So for instance, like when you're talking to a client, maybe you've initiated and you're talking about going up or down on doses, trying to find the right one, whatever. Saying without really thinking, something like, do you feel like you need to go up on the dose, whatever. If that patient says, oh yeah, I do actually, um, not having meant that question or not being aware of the way you asked it, it's not meaningful choice, because if that patient says yes and you kind of say, oh, well, I don't really think that you need to or that it's necessary, whatever, don't ask the question, is my point. Only ask questions that, you can, I guess, don't ask questions that you don't mean. Don't kind of say things in a way that the patient thinks that, their opinion matters and whatever, because it should automatically, but realistically, it doesn't always. And then go against that, because it's going to put, it just leads away from trust, and so the idea of collaboration, I know it's a buzzword. I get it. Like, I'm tired of hearing it too. And people who use drugs have oftentimes never been listened to. Their opinion has never mattered. Nobody has ever cared. So if you're asking what people think is best for them, which again, we should be, but it doesn't always, follow that. If you mean when you ask somebody, oh, what do you think, da da da, and they give you an answer, please respect that and act accordingly. Don't ask the question if you can't actually, if there's not actually if there's not actually a choice there for the patient, it's incredibly harmful, like I said. So because I've gone so over time, undoubtedly, and I am getting looks here, I'm going to stop talking and pass it on to, I'm not too sure, one of you.
I'll just step in and say thank you so much, because I think in very worthwhile minutes, you've given us a lot to think about. And I would say, as someone who's been working in this space for quite a while now, it's still hard to hear, when we think that we're being helpful, that some of what we're offering or how we're offering it isn't, and that people, are still experiencing so much bias and judgment. So I have the strong feeling that people in the session are here because they really want to do it right. And you've given us a lot to think about in terms of what that means, right? And the main thing is being present and listening and being, I think you've said, not just collaborative, authentic, right? Don't offer things that you're not prepared to follow through on, engage in meaningful conversations and really listen. So I hope there'll be some other times for you to jump back in. And if there are things that I say or ways that I say them that don't feel like they're appropriately patient-centered, feel free to step in and correct me. I'm speaking for Nikki. I'm sure she would want the same thing too. So we're going to get a little bit more technical for a little bit and try to keep this all though relevant and thinking about it in the vein in which Em has presented it. So what is Suboxone? We just thought it was really important briefly, although we're not supposed to talk about brand names of things, but it's, as Em said, buprenorphine naloxone is a lot of syllables for any one of us to use. Suboxone is the trade name for tablets that contain both buprenorphine and naloxone. And in Canada, that's the most common way that that the medication is available. There is a brand name and generic. The common tablet strengths are 2 milligrams and 8 milligrams. And the buprenorphine and naloxone are combined in a fixed ratio. So the 2 milligram tablet is 2 milligrams of buprenorphine with 0.5 milligrams of naloxone. The 8 milligram is 8 milligrams of buprenorphine with 2 of naloxone. You don't, in most, let's say like EMRs, if you're writing a prescription, you don't need to think about that. It should pop up, but sometimes you might need to know. And the odd time people can get confused actually and think about dosing the naloxone strength, which is totally inappropriate. There's also Suboxone film, same strengths, but attaches to the buccal mucosa and dissolves more rapidly. It's not covered on ODB in Ontario. So I have an Ontario lens here in terms of thinking about what's covered. So in Ontario, the 2 and 8 milligram tablets are covered on our drug formulary. There are other strengths that are not, and so we tend to not use them a whole lot. The film is not covered. There is long-acting injectable buprenorphine, which goes by the brand name or trade name Sublocade. If we have a moment to talk about it later, we can. It's a great option, and I think there's a whole other session on it. It can be used once a month to help maintain people who have trouble getting to a pharmacy regularly. And then many of us might know the Butrans patches, which are much lower dose and are used for pain management. But the point is buprenorphine is buprenorphine. It's packaged in different ways. It's the same molecule. So we want to know a little bit about it. What is buprenorphine? A long-acting partial opioid agonist with a ceiling effect. That's kind of the buzzword. Long-acting means that it can help to prevent withdrawal symptoms for 24 hours and beyond. And that partial opioid agonist can also extend to pain, although we often find that for pain, it requires dosing more often than just once every 24 hours. It has this high affinity, so it binds very strongly to the opioid receptors. I'm going to show you that in a minute. It works to block the activity of other opioids, which reduces their effect. And because it's a partial agonist, it doesn't have as much effect as a full agonist. That would be something like morphine. And so there tend to be fewer side effects overall. And then it has this neat thing called the ceiling effect that I'll show you just quickly. So imagine this is your full mu opioid receptor agonist like morphine, heroin. The molecule attaches really nicely into the receptor. It activates a whole cascade of other chemicals. The sort of, common theme and things that make us feel good is dopamine, but there are other neurotransmitters that are released. So that works on pain, can produce some euphoria and pleasurable feelings. And when someone is habituated to having an opioid in their system, and then that opioid is withdrawn, they experience withdrawal, which is an awful feeling. Sweats, chills, goosebumps, runny nose, tearing, upset stomach, whether nausea, vomiting, diarrhea, headache, anxiety, agitation. People who've experienced opioid withdrawal rightly are very fearful of it and don't want to experience it again, and will do lots of things to try to avoid that. So we add in buprenorphine, and you can see those nice little green balls that they sit on the receptor, but they don't fill it. They don't attach as nicely as the full agonist. And so they give that partial activity rather than the full activity, but they also block the other opioids from attaching. And so if someone uses another opioid while they're on buprenorphine, they don't get the same full effect, whether that is pain relief, they still get some, or the euphoria or other kind of buzzy kind of feelings. And then the ceiling effect that I mentioned is also a really important element in why buprenorphine is safer, not just than methadone, but than virtually every other kind of opioid. Because at a certain point, it has this ceiling effect on respiratory depression, whereas with other opioids, the higher the dose, the more it depresses the respiratory drive, which leads to overdose risk when people fall asleep and stop breathing. With buprenorphine, when you get to 24, 32 milligrams or so, it doesn't have any additive effect on respiratory depression, but higher doses do continue to have more effect in terms of the opioid effect overall. Nikki, to you.
Okay, that's me. So let's say you get this discharge summary. It says, thank you for taking over the prescription of buprenorphine for your patient. They started on buprenorphine in February through the RAAM clinic and have been on 16 milligrams daily for the past 2 months, and it's taken 8 milligrams BID. They've been picking up medicines every 2 weeks. They have no ongoing opiate use and no other problematic substance use. Their current prescription ends May 31st. So the provider is telling you a lot of things here, and we'll go over it. But one, they're telling you, the frequency of pickups of the medicine. They're saying that they get the medicine every 2 weeks, which suggests some degree of stability on the medication. And they're telling you the end date of the prescription. And that's super important because they're suggesting as of May 31st, there's not going to be a script ongoing. And so could you please make sure that you write one? And so one of our primary care colleagues kindly wrote out this list of all the scary questions that they had. And hopefully we're going to go through one by one quickly to kind of answer this and make it less scary. So how long will they be on bup? How often do I need to see this patient? What are observed doses and carries? Will I have to do urine drug testing? How often? What are the implications? What about missed doses? Do I need to work with a specific pharmacy? How do I write scripts? When do I adjust doses? What else do I need to think about? Where do I get help if I don't know the answers to these questions? So all really important. And here we go. So let's start with the frequency of visits. So that there is generally a trajectory of OAT care. The early phase is called early stabilization, and then late stabilization. And typically, the natural course would be more frequent visits as we titrate the dose, and then relaxing the frequency of visits as we go. There's no, mandatory, at least in Ontario, frequency of visits. So really, this should be a discussion with the patient about what works for them. Thinking of patient-centered care, we want to make this treatment accessible and easy for the client. Also recognizing that it's good, especially if you adjust the dose, then you're going to want to see the client more regularly. As the client has been on a stable dose, you're relaxing the visits to maybe monthly. And in the case of someone who is very stable and doesn't need to be seen, just like any other chronic disease, for example, your hypertension clients or your diabetes management clients, you might not see them, but every 3 months, for example. So what happens at a visit? Well, typically it's an opportunity to review the client's substance use, how they think their treatment is going, any urges and cravings, mood and function, any other health issues that are ongoing, psychosocial update, other things like family, kids, other psychosocial goals, for example, return to school, medications, any test results, and of course, goals of care. So assessing the dose, how do we decide if someone's dose needs to go up or go down? Well, we assess it subjectively based on withdrawal symptoms, thoughts, urges, or cravings, whether they have ongoing opioid use. So, for example, if the person says, the Suboxone's really working well for me, but I still feeling like near the, just before I get my dose that I'm going to withdrawal, sometimes I'm using some extra Dilaudid or hydromorphone on top at that time. Well, maybe that's an indication, if the client is open to it, to go up on the dose if their goal is to reduce or eliminate their other opioid use. And then if they experience sedation, for example, or other side effects like constipation, headaches, maybe that's an indication to go down on the dose. And of course, mood and function. So typically, buprenorphine is dosed in a range of 2 to 32 milligrams, although the pill can be split. So actually the dose could be, as low as 0.5 milligrams, and then all the way up to 32 milligrams, although in Canada, doses above 24 milligrams would be off-label. So historically, we thought that doses of 12 to 16 milligrams best retain people in treatment, but there's emerging evidence that doses even higher, especially in the era of fentanyl, so doses greater than 16 milligrams within the first 30 days of treatment, are associated with reduced mortality. So the dose that our client is on, 16 milligrams, that is within the usual dose that retains people well in treatment. But you can, certainly if they were experiencing cravings, et cetera, you have room to go in terms of dose increases. Usually the medicine's taken once daily, as we said, but it can be divided twice daily, especially for patients with chronic pain and opiate use disorder. And the correct dose is the dose at which the person feels normal. So over 24 hours, no sedation, no withdrawals, and ideally no cravings. And for clients with pain, we want to focus on their functioning. So what are they able to do? Are they able to get out, do the things that they need to do in their day-to-day life? Over to Jennifer.
Oops, thanks. I was looking at that question. So writing buprenorphine prescriptions is just a little bit trickier than writing any other prescriptions that we do, because usually we try to be specific about start and stop dates. And in most cases, the pharmacy will pick up if there's an issue, but it just saves a lot of effort if we're careful enough to think about when the prescription ends so that they don't overlap and we don't have to deal with all of this pharmacy back and forth. Really, the most important thing is to try to make sure that we think about having an appointment for the person to come back before or just at the time that their prescription ends, so that there's no gap in care. It's really, really stressful for people to think about not having a prescription, not knowing if their prescription is at the pharmacy, and going into withdrawal because, as we said, there's so much fear of withdrawal overall. So we think about what the dose is, we write it in the milligrams, so whatever number of tablets that would be, a start date and an end date. And I know that there are questions about what is an observed dose versus a take-home dose, and a lot of that comes from the world of methadone, where people were started on methadone and expected to attend a pharmacy every day for a long period of time to have an observed or a daily witnessed dose. We moved away from that in buprenorphine prescribing even before the pandemic, and then more so through the pandemic. Buprenorphine is a much, much safer medication than methadone for some of the reasons that we touched on briefly. And so when we're just getting someone started on buprenorphine, we might have them go to the pharmacy once or twice a week just to sort of keep things organized. But we very, very quickly go to just picking up medication once a week, then every 2 weeks, or then every 4 weeks. And the reason I say 4 weeks on a day of the week is because the whole 30-day thing just kind of starts getting confusing. People get used to a routine of picking up their medication on a Saturday, let's say, because it doesn't interfere with their work so that they can go to the pharmacy and pick up their medication. So we tend to write it in those cycles. And I'll show you a sample prescription. I very rarely now have people take their medication actually in front of a pharmacist as a quote unquote witnessed dose. So this is an example where you can see that the computer program says buprenorphine 2 milligrams, naloxone 0.5. The daily dose is 2 milligrams. It's sublingual. That's really important. I think most patients have learned this, but the medication is not absorbed. It's not effective if it's swallowed. So people have to hold buprenorphine tablets in their mouth, not eat, talk, or drink for the 5 to 10 minutes that it takes for that medication to absorb. So in this case, it says observed doses. That really means that they're taking a dose at the pharmacy, or we can be specific that they don't have to actually take it there. They're just picking up their medication for the week. Their take-home doses are the other days of the week, Tuesday to Sunday. There's 28 days on here, and you can see that there's a start date and an end date. We ask the pharmacy, and this is usually just kind of added to every prescription, so it auto-renews. Let us know if the person missed any significant doses, more than 5 doses. There are some considerations. If the person looks unwell, of course, we want to know that also. But that's not really different than with any other opioid prescriptions, I would say. So similarly, in line with other opioid prescriptions, we want to make sure that people aren't running out of their medication. We want to make sure that medication is stored safely, so it's out of sight and out of reach of others who could access it and shouldn't be. So a lockbox is a very good idea for any kind of opioid medication. And if you're on a regular 4-week cycle, but you're going to be on vacation, or someone picks up on a Monday, but it's a long weekend, that's not good. So we want to plan ahead. And sometimes that 4 weeks is going to be 6 weeks. And again, look ahead in the calendar, plan the follow-up assessment for before the medication runs out. Don't leave someone stranded on a long weekend Monday. Urine drug testing. I think that's me as well. And hopefully we have a few minutes for questions left at the end. I think this is another area that has felt like a barrier to including buprenorphine prescribing in primary care, because people have this impression that it's like a methadone clinic, quote unquote, where people are expected to come in once a week and leave a urine sample for drug testing, and have all of this complexity around assessing the number of take-home dosing. So I think what we really want to convey is that prescribing buprenorphine is like prescribing another medication for people who have a chronic health condition that you would manage in your practice. It's really not more complicated, and it's a lot safer than a lot of other medications that we prescribe really regularly. So in terms of urine drug testing, there is a role for it in managing opioid agonist therapy, but it's not something that needs to be done on a very routine basis. It's helpful when we're starting people on treatment to get a sense of what they're using, and identify that what substances are in their system, and making some decisions around treatment initiation. It's helpful when we're thinking about take-home doses to know whether someone is taking their medication, whether they're taking other things that could interfere with their safety or their stability or the medications that we're prescribing. It demonstrates that they're taking their medications. And in terms of other substances that affect safety, it's not only unregulated substances, but things that are prescription medications and other things we could even be prescribing, like benzodiazepines overall. So usually we use it to look at a conversation around what the person, it always has to be in line with the conversation with the individual about how they're doing with their medication, how they're doing in their substance use, what their goals are with respect to substance use. And what we hope is that what we see on a urine test is in alignment with what they tell us. And that's really the ideal situation. So this is drawn from the BC CSU guidance on urine drug testing, just to sort of give you a framework for frequency. So as we said, at initiation, it's useful. And then when clinically indicated. So for someone on buprenorphine, that would be, when you see them once a month or every couple of months. So roughly in alignment with your visits. Do you need to do a test in the office, a point of care test with a dip? No, it's very convenient if you already have those tests and it's part of your practice, but there's really no reason that they need to be brought in and to worry about creating a whole additional workflow if it's not something that you do regularly. In that case, you would give the patient or the person a lab rec that says broad spectrum toxicology. They can either leave the urine sample in the office if you've got a lab pickup, or they can go to the lab to do their sample there. And you're going to get the results back within just a few days that shows the buprenorphine, naloxone, and any other substances in their system. If it's all in alignment with what they've already discussed that they're taking or using with you, then that's all great. If there's a surprise, then obviously that's something that needs to be talked about, and ideally not a month or 2 months later. So that's the advantage of having a point of care test where you can review those results in real time. But if that's not the case, then you would follow up on an abnormal result, just as you would with any other abnormal result with your patients, right? Whether it's a blood sugar or a thyroid that needs to be discussed, to say, have a conversation about what's the disconnect here, and should there be an adjustment? For example, if someone is using other substances, other opioids, but they maybe weren't telling you, maybe that's because their dose really isn't working for them and they need a dose increase, but they were reluctant to suggest that for some reason. And this is an opportunity to have that conversation, talk about safety, and talk about goals all over again. And that gets me back to Nikki.
Yeah, so the question is, when would we increase the dose? Again, based on subjective symptoms. So any withdrawal symptoms, sweats, chills, restless legs, upset stomach, poor sleep, and starting before they get their next dose. If there's resumption of opiate use or ongoing difficulty or stopping or reducing opioids, if that's their goal, then that would be an indication for a dose increase. If there's cravings, thoughts, urges to use, or an increase in other substance use, for example. Usually we increase the dose by 2 to 4 milligrams with planned follow-up in 1 to 2 weeks, again, depending on the patient's circumstances. And obviously, if you don't have availability for 2 weeks, that's okay. Where are we going next? Oh, here we go. So just a note on treating pain in clients on OAT. So opiate agonist therapy, that's OAT, doesn't provide adequate analgesia for acute pain. There's reduced analgesic effect due to tolerance to opioids. And there's also a shorter duration of action for analgesia. So people on OAT need higher doses of opiates for analgesia. There's cross tolerance between opioids. There's neuroplastic changes, which could lead to hyperalgesia or increased pain. And there's also stress associated with unrelieved pain, which could be a potential trigger for relapse to opiate use. So the best practices, let's say you have a client, I don't know, they are stable on their buprenorphine, but they fall off their bicycle. They have a cracked rib, let's say. So they're going to need some analgesia on top of that. So the best practice would be to continue their buprenorphine and make sure that the patient receives the dose even if they miss the pharmacy pickup. Treat the pain with multimodal strategies. Obviously, you're going to optimize anti-inflammatories, but you're also going to use short-acting opioids on top. So typically, we might use hydromorphone on top, and you're going to need to use doses that are higher than typically used for treating that pain. And of course, you want to communicate if you're not the primary OAT prescriber. Hopefully you're prescribing both, but if you're not, then you want to communicate with their OAT prescriber to ensure smooth transition. So certainly if certainly if, for example, they're discharged from surgery or something, you're going to want to know from the surgeon, what's the typical course of pain in this condition? How long can they be expected to be on opioids? And you're going to anticipate in advance that they're going to need higher than what another patient might need. So we're going to have some cases on this also in the next sessions. So this is a great place. You know, I haven't put details here, but there's lots of things to discuss further. Okay, I need to move along a bit faster. So we talked a little bit about, and our colleagues with lived expertise have talked a lot about the fact that the program can be strict. People don't want to be stigmatized. The medicine can have side effects and costs. And for all these reasons, sometimes clients request discontinuation of their medication. So indications for dose decrease, well, sedation or side effects, and of course a planned taper. So when following, you need to have a discussion about what are client goals and help them decide in conjunction with you, what's the safest way to reduce their dose. So it's always client choice. So if client comes to me and says, you know, I just want to get off this medicine, usually my response is, thanks for letting me know that things aren't working out. Is there anything we can do to work together to make this more accessible for you? For example, are the pickups too frequent? Is there other challenges with the medicine? Are you having side effects that we might be able to address? Is it too costly? Can we find a less costly option? You know, what are the issues? We know that people who stay on buprenorphine long-term have a reduced risk of opioid overdose and other positive health outcomes. And so we do consider it a chronic medication, meaning that clients should never be forced off the medicine. And, you know, chronic maintenance on this medication is completely a normal expectation, just like someone, you know, with diabetes might be maintained on insulin, for example. However, like we said, for the reasons that we've already mentioned, many clients have a goal to reduce their buprenorphine or to get off the medication. And so what you want to do is just try to make it as safe as possible. As I said, if a client says like, no, thank you, I understand all these risks, I'd still like to taper, then that is of course their prerogative, and then you should facilitate that. So just touching briefly, what do we know about buprenorphine tapering? This is just an area of my research based in Ontario. So what we know is that tapering buprenorphine is fairly risky. The risks of destabilization are high. Treatment with buprenorphine should be continued for as long as patients benefit from it and want to continue with it. But for patients who want to taper, the bottom line is that you should go slow and have a low barrier for treatment reentry, meaning we should start a taper typically after at least a year on therapy. Of course, if client wants to taper before then, that's their choice, but high risks of return to opioid use. A slower rate of taper, so that's less than 2 to 4 milligrams per month typically, and dose reductions every 2 months or less. These things are all associated with a lower risk of opiate overdose, and then having that really low barrier to return to treatment. So if it's not going well after the taper, that the client knows that either they can restart on their own, like they have a small supply of buprenorphine, for example, at home that they could restart if they needed to, or low barrier access to get in to see you. Lastly, I think we're touching on management of missed buprenorphine doses. So the bottom line is if it's 5 or less doses, you're going to maintain the current dose. They miss 6 or more, then it's a restart. And we haven't touched on how to restart yet, but we're directing you to some resources, the MAC Health Buprenorphine Reference Guide, the CAMH ODT Guide, or call any of your rapid access addiction medicine colleagues, and they can guide you in restarting. Where to find help. If you go to the Medify website, you can see all the rapid access addiction medicine clinics in the province of Ontario, and you can actually put in a postal code or address. Jennifer's put it in the chat, and then you can find the RAAM clinic that's closest to you. I can assure you that all of our colleagues would be happy to take a call from you to best support their clients. This is the CAMH course. It's an online course that you can do at your own pace in your own home. Jennifer, over to you.
Yeah, this is the reference guide that's associated with the MAC Health course, which is 6 modules in total on opioids for chronic pain and opioid use disorder. And the reference guide can be downloaded. It needs a little bit of updating in terms of things like take-home doses, but the basics around how to start buprenorphine, home starts, microdosing, sample prescriptions are all in there. So I would encourage you to look at that as well. Um, and yeah, the AFMC also put together their response to the opioid crisis, which has modules for learners, undergrad, postgrad, and for faculty development as well. So there's a lot of great resources there. So I think, yeah, we're pretty close to out of time, hopefully a couple of minutes for any questions. Katie, I see you put a question in the chat. Can you speak to difficulty in initiation to bupe for some patients and how to make this transition easier? Sure, really briefly. We didn't want to overwhelm people with things that make buprenorphine seem more complicated, especially since if you're taking patients from RAAM, likely they've been started already. But we talked briefly about this idea of, that's okay, this idea of precipitated withdrawal. So if you think back to my slide about how buprenorphine has this high attachment to the receptor, but doesn't cause complete, like the full opioid agonist effects, what Katie's referring to is that if someone has recently used a full opioid like oxycodone, let's say, or fentanyl, when they take buprenorphine for the very first time, the buprenorphine kind of pushes that other opioid off the receptor, but doesn't fully replace it. So it can leave people feeling like they're in very nasty withdrawal. So the two main ways of avoiding that situation are either to have someone who's already in withdrawal, where the buprenorphine is just going to attach and make them feel better right away. And that usually is feasible with a short-acting opioid like oxycodone, for example, or short-acting morphine within 6 to 8 hours when someone starts feeling like they're in withdrawal, or with a content-type preparation, 12 to 16 or 18 hours from last use when they feel like they're in withdrawal, they're really good to go. For people who have taken those opioids more recently or would have trouble stopping them and leaving enough time to get into withdrawal, there's something called microdosing, and that information is in the buprenorphine reference guide. There is information on the Medify website as well, and that involves restarting buprenorphine at very, very small doses and titrating it up daily so that there's no kind of fighting with the other opioids. It just gets to a full dose very gradually and starts taking over more and more of the receptors overall. But if someone was recently on buprenorphine and they missed 5 or even 6 doses, they're still going to have buprenorphine in their system. That's what Nikki was speaking to. And so even if they've been using other opioids at the same time, your best bet is to get them back on a dose right away. If they're apprehensive because they've had challenging experiences in the past, you can give a test dose, a bunch of 2 milligram tablets, and just kind of do, 1 tablet at a time till they're feeling better and making sure that they get to a dose that is managing their withdrawal overall. But I'm sure some of these questions are going to come up in the next session around cases. So yes, just to echo what Nikki said, please, join us in the next round to hear more about some of the ins and outs. I hope this has been a useful start. A course you can register for. I think, Nikki, that was related to the CAMH OUD course, which you could find on the CAMH website in terms of continuing. If you put in continuing education, opioid agonist therapy, buprenorphine, any of those, then you'll find that overall.
Yeah, just to mention that the CAMH course has a fee. It's a great course. I'm the director of it, but there's other courses that are free. For example, the MAC Health course, as well as the AFC faculty development modules. Those are both free and accredited. So those are great options to start with. And then if you felt like you needed more additional training, then of course the CAMH course is there as well. But I'm also happy to take questions. If you feel like you need someone to hold your hand the first time you're prescribing it, like feel free to send me an email. Literally, I'll hold your hand as you do that. And I'd be so happy to do that for you.
Yeah, likewise, that's a great offer. And I would also invite people to explore the Medify website and the Medify listserv, which is a great community of practice also for people who are just kind of entering the field or experienced. If you have questions, clinical questions that you want to share, you're wondering about where to find resources, meetings, etc. All the information for joining the listserv is on the website as well.
Okay, on to the next session, I think. I just want to thank Em and Jennifer and our moderator, Stuart, for all their help today. And we are totally open to feedback. This is the first year that we're running the primary care stream. So if you could please let us know if this is useful for you at the right level, etc. That would be most helpful. Many thank you.
Yeah, special thank you, Em, for joining us from the East and with your lived experience. Really eye-opening and thought-provoking for us.
Always a pleasure. Thanks for including me.